Oh my gosh. Thank you, Dr. Jagannathan, for all the work you're doing on behalf of this community to give us a blood biomarker. That would be insane. Yay. Again, please consider, if you haven't already, donating blood right next door. If you haven't already done so, University of Colorado team is here, ready to suck it right out of you. So thank you again. All right. So next, I'd like to welcome Dr. Nicol Voermans from the Radboud University Medical Center in the Netherlands. She's come a long way to talk to us today, who's going to show us the broader view of treatments for FSHD. Welcome, Dr. Voermans.
Thank you. Yes, thank you very much for the introduction. I'm working at the Neuromuscular Center at the Radboud University, where we are continuously involved with diagnostics and treatments for patients with various neuromuscular disorders, including FSHD. And I'm very happy to work in a team with not only neurologists, but also pediatric neurologists and rehabilitation specialists, and all the therapists involved in the rehabilitation of neuromuscular conditions. And you can see our team here. In the middle, you see Ingrid, our secretary and manager of the team. And the reason I'm standing here is also on behalf of her. Just a short introduction. I'm from the Netherlands, and the Netherlands is small. You count in miles. 1 kilometer of 1 mile is 1.6 kilometers. So the figures in miles would even be less. So patients travel across the country to visit a center. And the center I'm working in is the most east part of the country in Nijmegen. And we have a blue circle around us because we are one of the 2 FSHD centers of expertise. We have a lot of Dutch people, 17 million, and there's an estimation that we have approximately 2,000 patients with FSHD, and they tend to attend one of the neuromuscular clinics for FSHD. We also have a good patient organization for all neuromuscular conditions. It's called Spierziekte Nederland, and there's an active diagnosis working group for FSHD. And we have the FSHD Foundation, which supports fundraising, organized activity, and encourage the knowledge on FSHD among the Dutch population. And what it is like to live with FSHD is well illustrated, I think, by the keynote speaker 2 years ago. Many of you will know her. I think she's here, but I would... Oh, hi! Then I'm not going to meet you, I was hoping that. But I think her story very nicely shows what it is like to live with FSHD. Her lecture is online, and I refer Dutch patients to the lecture quite often. And also clinicians, because someone asked Nick Johnson how you can promote the knowledge of general neurologists about FSHD, and I think stories like this are really helpful. And what I tell patients very often is that don't get frustrated if your clinician does not know about FSHD. Just try to seduce him or her a little bit to get involved, to be interested, and refer to information like this lecture online. And we have an FSHD clinic every Tuesday morning, which is a combination of neurology and rehabilitation. And there we have questions about orthotics. Well, we cycle in the Netherlands, bicycle. So if that's not possible anymore, questions about tricycles, about how to keep fit, how you can reduce pain and fatigue, and how social participation can improve. If specific questions about the diagnosis are raised, people are sent to my clinic, to the neuromuscular clinic, or I attend the FSHD clinic. And some of the questions I receive from patients are my symptoms caused by FSHD, or do I have another muscle disease? Sometimes they are referred by a general practitioner with the question, do I have the same disease as my father or mother? What's the cause of the pain in my back? If a diagnosis of FSHD is already made, sometimes people ask me, how can I contribute to research? Or young women with FSHD ask me, can I become a mother? And that's all about treatment. And I don't know whether this FSHD patient, it's a photo which was online for a long time, is also here today. If not, well, maybe online, but come and talk to me, because I think it's very nice that you contributed to the photographs on the website. And this is about a cure. There is no cure for FSHD currently, but there's treatment, and that's what I will be talking about today. Because cure is part of treatment, but it's much more beyond cure. And if you look at the definition of treatment, that is much wider. It's a process that leads to an improvement in health, whereas cure refers to the complete restoration of health. And after a medical treatment, the patient then no longer has the particular condition anymore. And that's what we are thriving for with gene therapy. But there's an overlap between treatment and cure, but if cure is not possible yet, there's a lot you can do about treatment. And important is the difference made between disease, illness, and sickness. Cure is aiming at the disease, the biological process, whereas treatment focuses on illness, the limitations someone has, or sickness, the social role related to the disease. And the cure for FSHD, that's what many of the researchers who were here yesterday and on Thursday are working on, and what Nick referred to. It's focusing mainly on the dystrophy and muscle cells, which causes muscle weakness. And Nick tomorrow will also have a Q&A sessions on the biopharmaceutical companies, and a nice overview is available on the website of the FSHD Society. Treatment focuses on many other aspects, and these are the topics you have been talking about with your rehabilitation specialist or general practitioner. There are treatments for pain, chronic fatigue, sleeping difficulties, physical inactivity, and reduced social participation. And this treatment is personalized. It's about what does FSH mean for this person, and how can you, as a doctor, contribute to improving it. One way of looking at that is this metaphor developed in the Netherlands. It's called My Positive Health, and it's about all the axes of health. As a neurologist, I tend to focus mainly on bodily function, which you see on the upper top, and that is definitely reduced by FSHD, but there's much more, or other factors contributing to health, like mental health and well-being, quality of life, participation, daily functioning, and that's much more about what Gretchen was talking about this morning. And there's a lot of information on the website of the FSHD Society. Many of you will be familiar with this, but don't hesitate to inform your general practitioner or a neurologist who's not so familiar with FSHD with this information. And I do refer many Dutch patients who are well-speaking English individuals to the website of the FSHD Society. So it's good to know for all of you, the clinicians who have contributed, to know that the outreach of this website is far beyond the United States. What Nick also mentioned is the clinical care guideline, which was developed 10 years ago and published in Neurology in 2015. It's a guideline which can guide clinicians, those who know FSHD and those who are not so familiar, through the symptomatic management. It contains information on a number of topics, some of which are specific for FSHD and others which are more general. And it's good to know that June, on behalf of the FSHD World Alliance, have taken the lead in renewing these clinical care guidelines. She had a poster on the conference here yesterday and is in the process of finalizing the journal report on these new guidelines, and the extensive version of the guideline will after that also be available online. And it's a process in which FSHD clinicians worldwide collaborated in searching the literature, finding evidence for the best treatments available. And that, again, will help you to talk to a clinician who's not so familiar. One of the items is genetic testing. The question was also raised before. It is a complex genetic test, and the number of laboratories is limited. It's about different aspects of the genetic material, looking at the D4Z4 repeat, the number of repeats in there, and the presence of an A allele. And then you have FSHD type 2, which is another form, and other rare genetic causes. And to harmonize that, 2 geneticists have led a worldwide team of geneticists to write down in a medical article how FSHD should be diagnosed. This was recently published and is available online, and that's also a guide for clinicians and geneticists who are not so familiar with the diagnosis of FSHD. And there was a lecture on this yesterday. There's a challenge in the interpretation, and the way the genetic diagnosis is noted might be different. Sometimes it's the number of repeats is mentioned, whereas in older reports is a diagnosis in kilo basis, and there's a referral table. So if you have an older report and you need to have it transferred to the new way of noting a genetic diagnosis, there's information available online, or you can contact me and I will send it to you. And the repeat length, if you look at a large group of patients, is related to the moment at which patients start reporting symptoms or to the age at which a clinician will see signs of the disease. So if the repeat length is shorter, like 4, 3, or 5 units, it's more likely that at a middle age someone will have symptoms and show signs of the disease. Whereas with a repeat length of 9 or even 10, it's more likely that a person will present with the symptoms later in life. It's not only about genetic testing, but also about counseling about reproductive options. I think that should also be considered part of treatment. If you know you have FSHD and you would like to be a mother or a father, it's important to visit a geneticist and talk about the options you have. There are different reproductive choices for people with FSHD1 and FSHD2. And one of our PhD students, Sanne Vincente, wrote a nice review on this topic, which is also very helpful if you are visiting a geneticist who is not so familiar with this. And then the breathing or respiratory muscles. Respiratory weakness is a symptom in FSHD in a minority of patients. And the first symptom is often that at nighttime, when someone is lying down, the muscle strength of the diaphragm is insufficient for ventilation. And as a result of that, you have an accumulation of CO2, which is called hypercapnia. And people will not remark that. There's no one saying, well, I think I have hypercapnia. What people will remark is that the sleep is not such good quality. They might have nightmares or wake up at night frightened, or they have headache during the day, or they might be sleepy during the day, although they were in bed for 8 or 9 hours. And this can be assessed with a spirometry. It's a test in which people have to blow at a maximum strength. And it's important to test that not only when sitting down, but also when lying down. And this is not specific for FSHD, but it's specific for neuromuscular conditions. So if you have this assessed, make sure that the pulmonologist or other clinician is aware of what is changing in neuromuscular conditions in general, and that it's being tested not only sitting up, but also lying down. I often receive questions about the heart, because the heart is also a muscle. And this has been tested in a number of series. The heart muscle itself seems to be normal, but a minority of patients with FSHD have abnormalities in the electric conduction in the heart. This is called a right bundle branch block, and it's mostly asymptomatic, but it can be detected at a normal ECG. In general, the presence of cardiac abnormalities cannot be predicted from the severity of the disease or the repeat length. So if there are cardiac symptoms, you should visit a cardiologist and ask to be checked by ECG and a cardiac ultrasound. The patients with a short repeat and an early onset of disease might also have hearing and vision difficulties. And this can be checked in a regular way by a specialist in ophthalmology or ear, nose, and throat medicine. And then chronic pain and fatigue. These are complex topics which cannot be simply solved, but we address these topics in the rehabilitation settings where we look at many aspects or factors contributing to these symptoms. And there's quite a lot of information on the website of FSHD Society again. And I really liked the presentation of Kathy Matthews, which you can view online, where she said, well, the treatment process of pain in FSHD is a process, and there's not a magic solution which will help you to get rid of the pain immediately. But that's what all of you with pain will probably have experienced already. And then about exercise. The rehabilitation department in my hospital has a long tradition of research on physical exercise. Nicol Voermans is a rehabilitation specialist, some of you might know. She did a large study on FSHD patients in which people were invited to participate if they had chronic fatigue. And it was a 16-week intervention. One part of the patients start doing aerobic training with a home trainer and a physical therapist, and one part of the patients had cognitive behavioral therapy. This is a form of psychological therapy in which patients are encouraged to increase their physical activity in daily life. There were measurements done before, directly after, and 12 weeks after the intervention. And she concluded that both treatments arms, so training with a physical therapist and home trainer, but also the psychological treatment, led to patients who were physically more active, slept better, had less fatigue, and could participate in social activities better. Another program at our rehabilitation department is about self-management. It's called energetic, and it's about how you use your energy throughout the day. My colleague, Ria de Haas, will have a session about this afternoon, and some of you will participate in that. And it's about what we were talking about, a good metaphor for this, but it's actually about changing your phone to an energy-saving modus whenever the battery is low. And you can learn to do that. And we offer that to patients in the Netherlands, and we will talk about that in this session this afternoon. And this is a graph I often show to patients to tell them what happens in aging. This is not about FSHD, this is about a general population without FSHD, but it also happens in people with FSHD. So you have an increase of muscle strength and mass when growing up. It's maximum between the age of 25 and 35, and then it starts declining. I'm far beyond the middle life, so I'm already in the downgoing slope, and you can improve there in training and with a healthy lifestyle. And this is what I also show to patients who come to my clinic and ask me, referred by a general neurologist, with the question, do I have a rare inherited neuromuscular condition? But quite often, after the age of 50 or 60, it's a number of chronic illnesses piling up and a number of drugs being used in parallel with side effects. And this is also, if you're not having FSHD does not keep you away from the regular process of aging. So this might add up to FSHD. And that's where you can try to limit the number of additional diseases by a healthy lifestyle. And this might be the line of a patient who's moderately affected with FSHD. So below the level of normal in growing up, at the lower level of normal in early adulthood, and then going down more steeply. But there's some room for improvement. You will never reach the upper line, but you can improve within your boundaries. And that's a combination of physical training, but also mental training. And I think it's very nice that you can find information on this on the website of FSHD as well. One of the forms of psychological therapy is acceptance and commitment therapy, which is explained on this page of the website, but that's what we offer to patients in Nijmegen as well. And I think if you think back of what I showed about positive health, it will not improve physical function, but it might improve several other determinants of health and contribute to a little bit better life. This is another part of psychological support. And it's a very nice article in the New York Times 5 years ago about a person with a chronic disorder, not a neuromuscular condition, but she wrote about what she would have liked known before she was diagnosed. And this is about the process of losing friends, but also making new friends, of encountering people who don't want to understand what is going on, and how you can encourage others to be part of your journey or be part of the rope you were talking about. And I think that is extremely important. And I talk about this topic a lot also with adolescents. And if you ask a teenager or young adolescent, would you like to have some support? And then they will always say no, and they are away. But I think we should not ask them whether they want to, but just offer it as a normal or standard part of care. And I think your story is wonderful in that. One of the aspects is communication training. And this is a very nice young lady who made these photographs herself for us to be used in a medical article to explain to non-neurologists what facial weakness in FSHD means. And we talked with her about the program we're now designing on supporting young people in what does it mean to have facial weakness in communication, and how can you compensate with other measures for the emotions you cannot express with your facial muscles. It's about creating the right subtitles. And that's about FSHD in childhood. We're very happy that we started a study, a natural history study on children with FSHD almost 10 years ago, the results of which were presented yesterday, and I was very pleased to see that the other groups worldwide are now also focusing on children with FSHD. And the pharmaceutical companies will have to start with their trials in adults, but after that we'll continue with children, and all the knowledge we have obtained so far is very important for this. Two last things I would like to mention. You have a rare disease if you have FSHD, and just count on it that the doctor you will encounter in an emergency setting will not be aware what it is. So you have to carry on information yourself. That can be with such a very old-fashioned information card in your wallet, but you can also have an in case of emergency app on your phone. And make sure that your co-travelers, if you're going anywhere, are aware of that you have this condition and have some English language. Well, that's quite self-evident here, but that's what I tell my patients in the Netherlands. English information, carry it on you when you travel in your hand luggage, so it's there whenever you need it. And then finally, I added this slide because I talked to this friendly man last night. He told me about a bone fracture. This topic was raised by patients in EuroNMD, the European Organization for Neuromuscular Conditions. And she encountered quite a number of patients who suffered from bone fractures after minor trauma and encountered non-specific care in hospitals afterwards. And we organized an ENMC workshop in January on their initiative. So the patients initiated this, and we invited leaders on bone endocrinology from worldwide to Amsterdam, where these ENMC workshops are always held. And we talked the whole weekend about bone density, bone strength, bone health, in all the ways you can improve that. And there's an important report which I just finished this morning early when I woke up, and we will submit it soon. But the background is that there's an interplay between bone and muscle. So if you're not able to be physically active as normal individuals can, your bone strength might be a bit reduced. And if you're living in Colorado and have conferences inside like here all day, you don't see any sunlight, you might be low in vitamin D. And if you have difficulties in swallowing, that's usually not the case in FSHD, but might be the case in other neuromuscular conditions, you might have not sufficient calcium intake. And this together might contribute to a lower bone density and a higher risk of bone fractures. We will write another general key opinion leader paper about this to raise awareness for bone density in neuromuscular conditions. And that will then also help you to talk about this topic to your clinician. So I hope that I've shown you that treatment is much broader than cure, and that is needed also for the trials which are coming up. Because if you are a trial participant and want to benefit optimally from the trial compounds which are being tested or afterwards of the new drugs which are being available, it's essential that your general health is optimal and that you have been treated well. And I think treatment is the underlying part of what we call trial readiness, where we are working on in many centers. And that's what I wanted to talk, so I'm happy to take any questions if there's time. There's time for one question, I heard, but I will be around till tomorrow. So if you have other moments to talk to me, that's also perfect.
Thank you for your presentation.